Welcome back. This is Mark Purdue, and you're watching a video on amyotrophic lateral sclerosis. In this talk, we are going to discuss the typical components of a clinical medicine talk, the definition of the disease, epidemiology, pathophysiology, presentation, evaluation, management, and particular attention will be paid to prognosis. On the right, you can see a picture of Lou Gehrig, the man for whom the disease was formerly named. Lou Gehrig was a famous ball player, played, I believe, for the New York Yankees, and was cut down in the prime of his life from this terrible disease. Amyotrophic lateral sclerosis is a progressive fatal disease that is neurodegenerative, ultimately involving the motor neurons in the cerebral cortex, brainstem, and spinal cord. So if we can kind of just unpack the name, amyotrophic, A means without, myo is muscle, and trophic comes from the Greek tropho, which means nourishment. So muscles without nourishment, or simply muscular atrophy. In this photo here, you can see in the superior to the scapular spine, in the area of the supraspinatus, you can see that there's this hollowed out region of significant muscular atrophy. If you look over here, you can see that he has lost a great deal of muscular mass from his arms. Down here, you can see that in the interdigital space between the thumb and index finger, this hollowed out region is severe muscular atrophy. And then if you can look at his tongue, you notice that in normal tongues, we have that midline ridge, and the loss of ridge and the loss of the normal landmarks implies this kind of atrophy. In addition to the atrophy implied in amyotrophic, there is also lateral sclerosis. And if you look at this cross-section of the spinal cord of a patient with ALS, you can see that there is this plaque-like hardening in the lateral horn of the spinal cord where these motor neurons are. And it was said that medical examiners could actually squeeze the spinal cord and feel the stiffness of the gliosis from those plaques. So ALS epidemiology is thankfully comparatively rare, 1 to 3 per 100,000, and it's thankfully rare because the median survival is something like 3 to 5 years after the time of diagnosis. It is sporadic in about 90% of cases, meaning that in the general population it just occurs randomly, but familial in 10 or less % of cases. The peak age of onset is 58 to 63 years for sporadic disease, and then 47 to 52 years for familial disease. You may recognize on the right a picture of Stephen Hawking. He was kind of a rare case of ALS in that he was diagnosed at a typically younger age, and as a result of his position in life, he was able to use assistive technologies and was a prolific writer, and unfortunately passed away in 2018. So the pathophysiology is not well understood, but it has been proposed that it was ALS as a result of some complex interaction of glutamate excitotoxicity, the generation of free radicals, cytoplasmic protein aggregates, which ultimately lead to these sclerotic plaques. In familial disease, one potential cause is autosomal dominant transmission of a mutation of the SOD1 gene on chromosome 21. But there is a great deal to be learned about the pathophysiology. If we think about presentation, we know that this is a disease that affects motor neurons, but there are upper and lower motor neuron signs. On the upper motor neuron sign, we can see hyperreflexia. If you think of a correlate with spastic paralysis, this is going to be kind of spastic weakness. So hyperreflexia, clonus, when you forcefully engage flexion or extension of the ankle and you elicit these rapid contraction and relaxation. Babinski's sign, where you take the bottom of your reflex hammer and you rub it on the lateral plantar surface for stimulation, and a positive test is going to be that dorsiflexion or extension of the big toe and then fanning of the other toes. And that's just a supportive physical diagnosis criteria. And then spasticity, poor dexterity, they can't control where their limbs are going. If it affects the cranial nerve, which it will eventually, they'll have problems with inspiration, difficulty speaking, and dysphagia or difficulty swallowing. On the lower motor neuron side, we're going to see that muscular atrophy like we observed in the picture of the ALS patient. And this can include both appendicular, axial, as well as facial muscles. And then fasciculations, these kind of small localized involuntary muscle contractions that we'll look at shortly. In addition to limb weakness associated with signs like foot drop and weak grip, there are also unfortunately trunk symptoms. So the muscles of ventilation, if they become weak and atrophic, you can see where that's going to result in problems and ultimately require some form of ventilation. Now, it says bulbar onset, and that's, of course, referring to the brainstem. And so if it affects the motor neuron transmission to the cranial nerves, you're going to have problems with speaking, swallowing, and then visual disturbances as it affects the nerves associated with the extraocular muscles. One other thing is the so-called pseudo-bulbar affect, and this is emotional lability, or 1 minute being peaceful and happy and the next minute being angry or upset or very sad, this kind of up and down emotional component. In this video, I'd like for you to watch, this is an example of fasciculations or these low amplitude muscular contractions in a patient with ALS. In this video segment, I would like for you to watch as a neurologist examines a patient with ALS.
So, first thing to note, it seems like is that you have, it appears, lost a lot of muscle mass in your arms. Lift up your arms as strong as you can. Okay? Do the best you can. Okay. Are you able to move your legs? At all?
Not at all.
Not at all?
Not at all.
Okay. And your legs are quite stiff, although, so I'm having trouble straightening your legs. Quite stiff. And let me just test some of the reflexes. So pretty jumpy here.
So this patient is not ambulatory because of weakness in his lower legs. You could see that he lost a great deal of muscle mass in his upper body, and also we could see that he was exhibiting some mixed hyperreflexia and reduced reflex on the contralateral side. Let's listen to the patient talk as the
Thank you very much for participating.
Okay.
Why don't you tell me when you first noticed a problem with your health? How long ago was it?
About 4 years ago.
What happened? What did...
felt my weakness in my legs.
Okay,
That's what caused me to go to the hospital.
was one leg worse than
One
the other?
leg, but it was a weakness in both legs.
Okay.
From there, I was using a walker.
How quickly were you using a walker?
Maybe about 3 months.
So pretty quickly.
Very quickly.
Okay.
And I used a walker for approximately a year.
Uh-huh. And then what happened?
Then I went from walker to a power scooter.
So you can see that this patient's weakness became progressive to the point where he was relying on wheelchairs and transport. In this video, we're going to just look real quickly at the phenomenon of fasciculations, these very fine amplitude, uncontrollable muscle contractions. You might think of them as a cramp, but they are more focal and they have a lower amplitude than cramping. The management for amyotrophic lateral sclerosis is going to largely be geared towards helping the patient to be optimally functional and ultimately comfortable. There's a medication called riluzole, which is given twice a day, and it's been shown to reduce the progression of disease for perhaps on average of 6 months. But the decision to use that's going to be made in consultation with a neurologist, and they're going to have a difficult time trying to come to terms with the best decision in terms of longevity versus quality of life. These folks will also eventually need a PEG tube, and that's a percutaneous endoscopic gastrostomy tube, and that's way they can put the tube in the stomach and directly give them nourishment. Eventually, if they do exhibit pseudobulbar affect, dextromethorphan, the kind in just regular cough medicine, has been shown to be effective in treating the symptom, but sometimes it causes side effects like constipation. And then ultimately, as you can see, this patient on the right has a tracheostomy. So if the patient requires ventilation, they will have to get trached in order to maintain quality of life. That allows them to bypass a lot of the discomfort and allows them mobility that's not associated with endotracheal intubation. Unfortunately, these folks will also require fairly expensive forms of assisted devices. You can see that they've got the computer hooked up to a transmitter so that if the patient can look and find letters on this sheet, that they can try to communicate. In the last 2 weeks, in the New England Journal of Medicine, a combination therapy was released as an approach for amyotrophic lateral sclerosis, and the conclusion of these two agents was that it reduced the functional decline compared with placebo as measured by a particular score over 24 weeks, but unfortunately the secondary outcomes were not significantly different between the two groups. So this is another indication of although there is reason for hope, there is no near-term significant management for ALS. Now, the prognosis of ALS, like with MS, is definitely out of my scope of practice, but I think that if we can observe that the median survival is from 3 to 5 years, we have to come to terms with the fact that this is a fatal disease and ultimately needs to be under the care of a neurologist. This marks the end of the ALS video.